those. Patient-centered care, psychotherapy for cancer-related distress with Melissa Holt, DNP, PMHNP-BC and MSW, and Lisa Stewart, PsyD. So welcome both of you. So glad to have you here.
Thank you.
Let's see. We've got a full bio here, and then we're going to jump right over to our top three facts that we're going to share about you today. Melissa Holt is a board-certified psychiatric mental health nurse practitioner with the Comprehensive Cancer Support Program at UNC. And she received her DNP from UNC Chapel Hill in 2018 and spent time working in private practice in general psychiatry before joining UNC in 2020. And number one, prior to becoming a nurse practitioner, she was a hospice and home health social worker with several local agencies, a staff nurse on 4 oncology at UNC, and a nurse navigator with the GU Medical Oncology team. Melissa, welcome. Really glad to have you here.
Thank you so much.
And Lisa Stewart, PsyD. Number 3, Dr. Stewart received her PsyD from the Florida Institute of Technology and completed her pre-doctoral internship and postdoctoral fellowship with emphasis in health psychology at James A. Haley Veterans Hospital in Tampa, Florida. Dr. Stewart joined UNC faculty in 2021 and spearheaded the development of the Adult Consultation Liaison Psychology Service. And finally, Dr. Stewart is passionate about training at the next generation of mental health professionals and enjoys providing clinical supervision for PGY2 psychiatry residents and predoctoral psychology interns at UNC. Lisa, welcome. Glad to have you here.
Thank you very much.
All right, I mentioned poll everywhere. Here's the first question. This is usually kind of a softball. Cancer-related distress is very common and can impact a patient's quality of life, adherence, and treatment outcomes. That's a true or false? I'm going to flash up our disclosures, and let's go to the poll everywhere, and we'll wait about 20 seconds. I should have mentioned poll everywhere is totally anonymous. We're not going to call out anyone if they didn't get the answer we were looking for. So go ahead and take your best guess at that. Looks like we're trending pretty heavily on true. How are they doing?
So far, good. 100% correct.
Awesome. Awesome. Okay. Well, without further ado, psychotherapy for cancer-related distress, and I'll turn it over to the two of you. And again, thank you both so much for being here today.
Thank you, Tim.
Thank you. Thank you for the introduction and for having us. Melissa and I are excited to be here today to talk to you a bit about psychotherapy for cancer-related distress. And we're particularly excited about this topic because what we hear from a lot of our non-mental health colleagues is that there's a bit of uncertainty about what psychotherapy looks like for cancer patients and how exactly it can be helpful with certain issues that come up. So we hope that our presentation demystifies the therapeutic process and provides a clearer understanding of how psychotherapy interventions can effectively address the unique issues that come up for cancer patients. We can confirm that we have no financial disclosures. So today we're going to provide a brief overview of cancer-related distress and its impact on patients' health and well-being. And we're also going to present 4 fictional patient vignettes that highlight different aspects of cancer-related distress that we've found in our experience to be very common. And we will apply a different evidence-based psychotherapeutic model to each vignette to demonstrate how the therapeutic approach can be tailored to meet the individual needs of each patient. So in total, we're going to be discussing 4 psychotherapeutic modalities, and we could have an hour-long presentation on any one of these modalities. So we're going to give a broad overview of the nuts and bolts of each model. So after our presentation, we hope that you'll feel more comfortable discussing cancer-related distress, what it is and how it impacts patients' health and well-being. We also hope that you're better able to distinguish different psychotherapeutic modalities that can address cancer-related distress. And lastly, we hope that you have a better ability to identify specific psychotherapy interventions that can be used to address the many different ways that cancer-related distress could present for a patient. So what is cancer-related distress? It can be defined as the emotional, psychological, and social difficulties that can arise as a result of cancer diagnosis and its treatment. And this can occur at any point, from initial diagnosis to treatment, survivorship, and beyond. And it's very important that we emphasize just how common cancer-related distress is to avoid over-pathologizing. So people reporting cancer-related distress do not always meet criteria for a mental health disorder. We can all appreciate that a cancer diagnosis is inherently distressing and sometimes traumatic. And most, if not all, patients are going to have an appropriate emotional response to that. However, for some patients, cancer-related distress can significantly impact their quality of life, their treatment adherence, and even treatment outcomes. So fortunately, psychotherapy has been found to improve adherence for these folks and to result in enhancements of meaning and purpose and improvements in quality of life. And you might be wondering at this point, well, how exactly does psychotherapy do this? And the answer is it depends. The mechanism of change will depend on a lot of factors, including how cancer-related distress is presenting, because it can present many different ways for folks, and what treatment model is used. So to illustrate how psychotherapy can achieve some of these benefits, we're going to transition to those case vignettes. And again, each vignette includes a different way that cancer-related distress might pop up. And it will be matched with a specific psychotherapeutic modality that we think is a good fit for their particular constellation of symptoms.
All right. Thank you, Lisa. Our first case example. Here we have a 70-year-old male with a 9-year history of prostate cancer who recently learned that his cancer has metastasized to his bones, and he's now struggling with a lot of pain. He started feeling depressed last year and is finding that his depression has worsened as the pain has become intolerable, along with the recent news that his cancer is now metastatic. He is endorsing depressed mood, anhedonia, feelings of hopelessness, low self-esteem, fatigue, and difficulty concentrating. So in this situation, I'm choosing to use cognitive behavioral therapy, or CBT. And CBT is a solution-focused type of psychotherapy that is designed to reduce symptoms and boost well-being as quickly as possible. The cognitive component is changing problematic patterns of thinking, and the behavioral component is helping develop actions that serve us well. CBT has some core principles. It emphasizes collaboration and active participation. There are general principles and techniques, but it takes collaboration to tailor the therapy to the patient's specific needs, and that is collaborating with the patient. It's a crucial part of the work is defining the problem, which helps make the problem feel more manageable. CBT is rooted in the here and now. It focuses on how one's thoughts and actions in the present may be part of the ongoing struggles and how changing those patterns might help the patient feel better. And it teaches patients how to be their own therapist. What I mean by this is that the patient will learn basic skills to help manage distorted thinking and behaviors. And it emphasizes relapse prevention. If the patient gains understanding of what led to the depression or other mental health concerns, the patient can be on the outlook for, warning signs of a potential relapse. And this can be accomplished through practicing new skills. CBT is time limited. It offers relief in a relatively short amount of time, which is nice. It's structured, which makes it very efficient. And CBT helps address negative automatic thoughts. This is the biggest part of CBT. Negative thoughts can lead to negative behaviors and negative feelings. And CBT involves a variety of techniques. This can include techniques such as cognitive restructuring, relaxation training, behavioral activation, or exposure. The main takeaway is that thoughts and behaviors are the focus of CBT, and we can indirectly control our feelings by changing our thinking and behavior. So this diagram is an illustration of the CBT triangle, where the thoughts, feelings, and behaviors all affect one another. And I hope it becomes clear to you how they're all connected. So in our example of the prostate cancer patient struggling with depression, the negative thoughts could be something like, I have nothing to look forward to in life, which can lead to dysfunctional behaviors such as the patient starting to isolate himself from loved ones, which can lead to it can lead to feeling depressed. Socratic questioning or guided discovery is a technique to help patients gain distance or see their cognitions as ideas, not necessarily truths. It also helps them evaluate the validity and utility of their cognitions and might even help them stop catastrophizing their fears. So, for example, the patient says, now that my cancer has spread to my bones, I have nothing to look forward to in life. So, some questions to help the patient gain more insight in understanding the real truth might be to ask the patient, what makes you think you have nothing to look forward to? Or how strongly do you believe this is true? Or do you believe that all cancer patients have nothing to look forward to in life? Or another question might be, what would you say to your best friend if that person told you the same thing? And cognitive restructuring is changing those negative thoughts that people might automatically have to more positive thoughts. And it leads to a change in behavior and a change in the way they feel. So here are some cognitive restructuring strategies. The first one, operationalize the negative thought. If the negative thought is there's nothing to live for, ask the patient to define what makes life worth living for them. Evaluate the utility, implications, advantages, and disadvantages of the thought or the belief. And with this, get the patient to consider how the thought is serving them. You want the patient to start seeing the thoughts as maladaptive or unproductive. You want the patient to see the cost of thinking this way. It doesn't feel good to be depressed. You could help the patient discover how this negative thinking is preventing them from seeing the joyful aspects of life, and among other things. We want to evaluate the accuracy of the belief, showing evidence for and against what they're saying, and evaluate the alternative ways of thinking in this situation. So ask them, what would you say to a friend if a friend told you the same thing? Help the patient align how they treat others to how they would treat themselves. And here we have automatic thoughts, which are also known as cognitive errors, and they're actually also known as cognitive distortions. With all or nothing thinking, this is seeing things in extreme terms. So an example might be, things are hard now, so there is nothing to look forward to in life. Catastrophizing is a common thing we see where the patient is thinking a situation is much worse than it is. And an example of this might be, my pain is worse today, so I'm probably going to die soon. Emotional reasoning is assuming our feelings convey useful information. And an example of this might be, my depression is worse today, so that probably means that my cancer is worse than what they're telling me. Discounting the positive is minimizing the evidence that contradicts one of their negative thoughts. So an example of this might be, my family made me laugh last night because they feel sorry for me. And fortune telling is making predictions based on very scant information. An example of this might be the doctors are so busy that they aren't going to give me the best treatment options. So now we move to a poll everywhere question. So the first question, the CBT triangle illustrates how the following affect one another. Is it A, behaviors, situations, and thoughts? B, thoughts, behaviors, and feelings? C, thoughts, ideas, and behaviors? Or D, negativity, thoughts, and feelings? You guys are good. Okay. Yes, it is B, thoughts, behaviors, and feelings. All right. Now we're going to move to a new vignette with Lisa.
All right. So in this case, you'll see we have a woman who has recently completed treatment for stage 2 ovarian cancer, and she's really struggling with anxiety and worry about cancer recurrence. Fear about cancer recurrence is very common for patients after cancer treatment and can occur regardless of cancer type or their overall prognosis. And in many cases, anxiety about recurrence is somewhat reasonable, particularly for those who do have a higher risk of recurrence. However, when anxiety and worry become so severe that it's interfering with functioning and well-being, as it is for this patient, that's an indication that additional support might be needed. So as with any of these cases, there could be a number of different treatments that could be helpful. One that comes to mind for this particular issue, which is very common, is acceptance and commitment therapy, or ACT. And as we go over this model, I'll explain why I think it's a particularly good fit for this type of problem. So ACT is a newer psychotherapy model that was developed in the 80s, and it's considered a third wave therapy. Third wave therapies incorporate interventions and skills that go beyond the more traditional cognitive-based models. So one of the key differences between ACT and cognitive-based approaches is that it is process-oriented versus outcomes-oriented. So outcomes-oriented approaches are ones that focus on reduction in symptoms or change in some other quantifiable variable. And these aren't always the best fit for problems such as issues with fear of recurrence, because again, sometimes these fears aren't always illogical or unfounded. And to some degree, it may be just not reasonable to expect that they're going to go away entirely. So instead, process-oriented approaches are ones that help patients examine and change the relationships with their symptoms rather than trying to eliminate symptoms entirely. So unlike CBT, which often emphasizes challenging and changing negative thoughts, as Melissa just demonstrated, ACT emphasizes acceptance of difficult emotions and thoughts. And ACT views psychological distress as a normal part of the human condition experience rather than something that can be eliminated entirely. And great emphasis is placed on mindfulness to help people develop greater acceptance of their thoughts and emotions and to cultivate present moment awareness. And ACT places a strong emphasis on values and helping people clarify what's most important to them. And treatment in ACT is focused on helping people live their lives in accordance with their values rather than just reducing symptoms that they're having. So the overarching goal here is to develop what is called psychological flexibility. And psychological flexibility refers to skills to manage negative thoughts and emotions in the face of adversity, so that patients can take actions that allow them to live a life that's most aligned with their values, despite their circumstances. And ACT was designed to be a brief treatment, and it has been manualized for 12 to 16 sessions. And it's a very active treatment. So patients are encouraged to be practicing these concepts in between sessions and may even be given worksheets or assignments to complete just to make sure that they're able to implement the concepts that are being discussed. So now that we reviewed the basics of ACT, we're going to dig a little deeper into the core principles. So ACT involves acceptance. This refers to acknowledging experiences without judgment rather than trying to rid of experiences or control experiences. And again, ACT places a lot of emphasis on mindfulness. So patients are given a lot of mindfulness exercises, such as diaphragmatic breathing, guided visualization. These are incorporated both into sessions, and patients are given mindfulness forms that they want to track their practice, and they're encouraged to practice this daily. And cognitive diffusion refers to learning ways to observe our thoughts and emotions from a distance. And this helps create space between the self and these experiences we're having, our thoughts and emotions. And this can help minimize being emotionally reactive to circumstances. And then patients are guided through a process to clarify their salient values and just consider and reflect on how aligned they are with those values in their current circumstances. And then we work with patients to set actionable goals so they're able to begin taking actions that are consistent with their values, regardless of their circumstances, so they can increase that alignment if they think there's a particular gap in a certain area. And lastly, self as context refers to shifting away from identifying oneself solely on the internal experiences we're having. So patients learn to recognize that emotions and thoughts are passing events and do not dictate identity. And by embracing self as context, we acknowledge our true selves extend beyond our momentary experiences. So this understanding enables folks to observe their experiences without becoming caught up with them or entangled with them. So if we think back to our patient in case 2 that's struggling with fear of cancer recurrence, which is interfering with her ability to sleep and concentrate, here's what a potential course of ACT might look like. So with acceptance, our main goal here is to help our patient accept the thoughts and emotions she's having about recurrence, as well as some of the uncertainty surrounding cancer recurrence, without judging them or trying to control them. And by doing so, a goal is for her to see how prior efforts to control or rid of these experiences have inadvertently created more anxiety or worry. And to demonstrate a lot of these concepts, metaphors are used. And so a metaphor that's often used in ACT to demonstrate the benefits of acceptance is the quicksand metaphor. So I hope that no one in this call finds himself in quicksand at any time. But if you did, an instinctual response might be to try to fight or claw your way out of it. And by doing so, you actually sink faster. So the harder you fight, the faster you sink. But if you need to get out safely, you'd want to lie horizontally, which allows yourself to rise to the top so that you may roll into safety. So again, the idea here is that we tend to have more of these unpleasant experiences the more we fight them. But if we can learn to acknowledge and sit with them, we're better able to move on with purpose, with meaning, and they don't have to dictate how the rest of our life is going to go. In terms of mindfulness, we would teach our patient actual mindfulness techniques that would be practiced in session to help her stay focused on the present moment and to observe her experiences without judgment or reactivity. And by doing so, we hope that by maintaining contact with the present moment, she has improvements in her ability to concentrate and attend to what's going on in the here and now. And we hope that it can also extend to sleep as well. This helps relieve some of the dysfunction she's having as a result of this anxiety and worry. In terms of diffusion, we'd work to give her tools to be able to create distance from her and some of those worries she's having about cancer recurrence. For instance, let's say she says, I couldn't handle a cancer recurrence emotionally or physically. We'd have her say, I notice I'm having the thought that I would not be able to cope with a cancer recurrence. And by having her acknowledge that it's a thought and saying that, this helps her separate herself from the thoughts that she's having so that she can realize that she does not have to believe or get caught up with every thought that enters her awareness. We work with our patient to complete a values assessment and treatment to help her identify her key values. And by doing so, hopefully cultivating a sense of purpose and meaning that's not tied to fears of recurrence. And then we take it a step further and we have her identify specific actionable goals that she can partake in that are aligned with these values. And she would commit to engaging in these values. And by doing so, she's building persistence and resilience. And although she may still have fears and worries about recurrence, they're not the ones that are in charge of her well-being. She feels like she has more control to be able to live life with value and meaning and purpose, and not based on fear. So to review a little bit about ACT, there's a lot of different principles we went over. Which one involves learning to detach from unhelpful or harmful thoughts and emotions and observe them from a distance? Yep, 100% correct. It is diffusion. And with that, we'll be turning it over to Melissa again for our next case.
It's a sharp group. All right. For our third case, we have a 56-year-old female with hormone receptor positive breast cancer that has completed surgery, radiation, and chemotherapy. She has been prescribed tamoxifen therapy for the next 5 years after difficulty tolerating an aromatase inhibitor. She is not consistently taking this medication despite receiving education that tamoxifen can reduce the chance of recurrence by 40 to 50% in postmenopausal women. The common side effects we see with tamoxifen are hot flashes, vaginal discharge, nausea, fatigue, mood swings, depression, and hair thinning. She has been fortunate to only experience a few of the potential side effects, hot flashes and mood swings. Despite tolerating the tamoxifen fairly well, she struggles to be consistent with taking this medication every day. So with this example, we see that the patient needs to be more consistent with her tamoxifen, and I feel like motivational interviewing is a super way to handle this problem. Motivational interviewing is patient-centered. We want to focus on the person and the therapeutic relationship, which means that establishing rapport is key. People appreciate your best advice if they feel you are trustworthy and you care about how they are doing. With motivational interviewing, or MI, we treat people like a partner in their healthcare, and we lean on their own strengths and their own wisdom. MI is basically conversing with patients about making a positive change and seeking to strengthen the patient's own motivation and commitment to do what is needed to make that change. In other words, you help the patient say why and how they might improve their health, not solve the question for them. Oops, went too fast. Sorry. Simply telling someone that they need to change their behavior is not enough to motivate them to make that change. You can't force anyone to make a change, and the patient is not going to change it without deciding for themselves if there is a need to change. So this means helping people make up their own minds and not pressuring them or using any coercion. So the role of the therapist is to draw out from patients why and how they need to change. You start with the wisdom and the abilities that the person has in front of you, and you prepare yourself to provide advice and information here and there as needed. In essence, you're basically a guide. So now let's look at the spirit of MI. The spirit of MI is partnership, autonomy, compassion, and evocation or empowerment. Partnership is the collaboration between your professional expertise and the patient's life experience. So the thinking here is that the therapist cannot fix someone's behavior. You get better outcomes if you put less pressure on the patient to make a change, and instead you help them to say why and how they need to change. Autonomy is respecting the patient's right and ability to choose what is best. Here we accept patients as they are and recognize their right to choose how they wish to live their lives. Compassion is a benevolent interest in the patient's concerns and needs. And MI is a way of helping them make changes that they perceive are as important within their own values and goals. And with empowerment, rather than telling the patient what to do, tune into the patient and use the knowledge that emerges through conversation to guide the helping process. MI is all about calling forth what patients already have within them, their own values, ideas, caring, and motivations for change. You cannot make life changes for patients, so you empower them to do it for themselves. And when MI is done well, you are helping patients literally talk themselves into making a change. There are 4 processes of MI: engaging, focusing, evoking, and planning. And these are not linear steps. They don't need to be followed in any certain order. These are just simply 4 activities that happen to occur when you're doing MI. So with engaging, you are showing interest and giving patients your full attention. With focusing, you are figuring out what kind of change the patient is willing to discuss and consider in the interest of their own health. And basically, you are choosing where to start, and it's like a negotiation between yourself and the patient. With evoking, you are discovering the patient's own motivations for change, for positive change. You're figuring out the why. And it's very tempting to simply tell patients why they should make a change, but it's important to step back in the situation and let the patient figure it out for themselves. With planning, you help the patient figure out how to best accomplish this change. And a common question might be, how do you plan to get there? With preparatory change talk, we are figuring out when the patient is getting ready to make a change. So when talking with patients about change, we have to pay close attention to the language that they use, because the language is an expression of their motivation for change. So for the example of the patient struggling to remember to take her tamoxifen, I would choose to listen for statements of desire, ability, reasons for change, and need. So with desire, you hope to hear words like want, like, or wish. And an example of a desire statement might be, I want to get better at remembering to take my tamoxifen treatment. With ability, you would hope to hear words like can or could. An example of an ability statement might be, I think I can make a better effort to take my tamoxifen every day. With reasons, you would hope to hear words like if then. And an example of a patient expressing a statement of reasons might be, if I take my tamoxifen every day, then it will decrease my chance for cancer recurrence. With need, you would hope to hear words like need, have to, or got to. And an example of a patient expressing a need statement might be, I've got to remember to take my tamoxifen every day. For mobilizing change talk, it's important to affirm, reflect, and summarize in order to help patients move towards mobilization through commitment and action. And we can reflect on a patient's resolution of ambivalence about making a change by listening for statements about commitment, activation, and taking steps. Change talk is the most important thing that we can evoke in a patient, where a patient actually makes a statement about their commitment to change. This occurs once patients have made a clear intention to change. When we hear that, it's very predictive that the change is going to happen. Activation refers to client statements about getting ready, getting prepared, and being willing to make changes. And we can identify when the patient is taking steps to make a change, when the patient actually tells you about discrete things they are doing and really changing their behaviors. Mobilizing statements are signs that the change is actually happening. So here are some change talk tips. And an easy way to remember these tips is by using the acronym OARS. OARS is a metaphor of we're paddling with the patient through some rough waters to try to get to a destination of change or recovery. And we want to use open questions, affirmations, reflective listening, and summarizing. So open questions, what we mean is helping them increase their talk time. You don't want to ask yes and no questions. You want to ask questions that's going to get them to communicate and talk. Affirmations, we help patients feel, you want the patient to feel understood by you. So this doesn't mean that you have to fully agree with what the patient's saying. You just are simply accentuating the positives and tuning into where the patient, to figuring out where the patient is coming from. Reflective listening is when you reflect the patient's thoughts and feelings back to them in an agreeable way. And it's helpful to do it as they're telling their story. And it's a great way to convey empathy while you're talking with the patient. And summarizing can happen periodically as you're listening to the patient. And it helps to synthesize and pull together the details that they're expressing. This step is key to helping the patient develop an integrated understanding, and it reinforces the working alliance between the patient and the therapist. Whoops. So now let's focus on MI and helping a patient improve medication adherence. So here are some questions that you might want to consider in the scenario that I've provided with the case example. You might want to ask the patient, where will the tamoxifen be kept? How does taking the medication fit best into your routine every day? What might be some good reminders to remember to take the medicine? What if a dose is missed? What are you going to do? And get them to ask, what would you do if you're tempted to stop the medication because you're having an unwanted side effect? So here's a nice little table about looking at change talk versus sustained talk. And this is why I'm saying it's really important to listen to their language. Because there's a big difference in how, if somebody's, you can tell when somebody's not wanting to make any changes. So for example, we can see that they do have the desire to make a change if they might say a statement like, I wish I could remember to take my tamoxifen. And we can see that there's a desire not to change if the patient says something like, I hate taking medicines. We can see that they have the ability to change with a statement like, I could probably motivate myself to take my medicine. And then we could see that they probably have not established the ability to do so if they say something like, I don't think I can make myself do this. We can see that patient has figured out reasons to change if the patient says, my family would stop worrying about me if I would just remember to take my tamoxifen. And we can see that the patient has not figured out a reason to change if the patient says something like, the doctors really don't know if this medicine is going to prevent cancer recurrence. We can see that the patient feels the need to make the change if the patient says something like, I've got to stay healthy for my kids. And we can see that the patient has not established a need to change if the patient says something like, lots of people do fine without tamoxifen. We can see that the patient is willing to change if they say, I'm thinking about being more consistent. And we can see that they're not willing if they were to say something like, I'm under too much stress at work to deal with any side effects. And we can see that they're committed to make this change if they might say, I'm going to start taking my tamoxifen. And we can see they're not committed if they were to say something like, I'm not ready to deal with any of this. And we can see that the patient is taking steps to change if they say something like, I've purchased a pill box and I'm going to keep it next to my toothbrush so that I can remember to take it before going to bed. And we can see that they have not been taking the steps to make change if they say something like, I haven't picked up the medicine from the pharmacy. All right, now Lisa will have our last case.
All right, so we're transitioning to our last case and treatment approach. And in this vignette, we have a man who has been recently diagnosed with a life-limiting illness. And understandably, this type of news would be devastating to anyone. And for this patient, who's at a point where he feels hopeless, depressed, and he desires a hastened death. So emotional and psychological support in this case would likely just be a puzzle piece in a much larger multidisciplinary approach for management, because these cases are often very complex and challenging to navigate. A treatment that could be an excellent fit for this patient would be meaning-centered psychotherapy, or MCP, because it was developed specifically for patients with advanced cancer at Memorial Sloan Kettering Cancer Center in the early 2000s. So MCP's roots are in existential approaches to psychotherapy. And existential therapies emphasize one's subjective experiences of life and explore issues related to meaning, purpose, freedom, responsibility, and mortality. So this approach recognizes meaning and purpose as fundamental human needs, and that cancer patients can experience distress when their sense of meaning and purpose is threatened by their illness. So MCP focuses on helping patients with advanced cancer find meaning and purpose in their lives despite the challenges of their illness. It's a brief, structured treatment that's been formatted for both group and individual psychotherapy. So I'd like for you to take a moment and read this quote by Viktor Frankl. And I imagine that many of you are familiar with Viktor Frankl. He was an Austrian psychiatrist, existentialist, and Holocaust survivor, and his work was integral to the development of MCP. And this is a quote from his book, Man's Search for Meaning, which details his experiences in concentration camps and describes the theoretical underpinnings of his psychotherapeutic approach, logotherapy. And this quote describes his theory in a nutshell. Regardless of circumstances outside of our control, we have the choice in how we respond to these circumstances. And with that choice, we are free to develop our own personal sense of meaning. So I think this quote nicely encapsulates MCP's theory, which is the idea that meaning and purpose can be intentionally cultivated when people are facing advanced cancer. So in terms of structure, MCP are guided through an exploration of their personal narrative or the story they tell themselves about their lives. And treatment begins with exploring the concept of and sources of meaning. So identifying key moments from their lives and from which they derive significant meaning. Patients also explore how their sense of identity and meaning has changed after cancer. And the treatment then delves into different ways and sources through which patients derive purpose and significance in life. So by examining historical, attitudinal, creative, and experiential sources of meaning, which we'll go in a bit more detail on the next slide. And lastly, treatment wraps up with reflection on the process of treatment, ways it's impacted their lives, hopes for the future, and how to implement concepts of treatment into their daily lives so that they continue living more meaningfully. So in terms of the different sources of meaning that are discussed in this treatment, historical sources of meaning are explored by having patients look back on their life and identifying the most significant factors that have had the biggest impact on them. For instance, their religious beliefs, relationships, participation in different activities. And they're prompted to reflect on the sense of legacy or the meaningful roles, accomplishments, relationships they're most proud of, and what they hope to pass on to others as their personal legacy. And when exploring attitudinal sources of meaning, patients are guided to reflect on significant obstacles they've overcome in the past, with emphasis on strategies that were used to overcome them, such as their perspective or their values. And then they confront the unique challenges that they're facing with cancer, whether it be their prognosis or loss of functioning. And this is really grounded in Frankl's theory that we have the freedom and choice in how we respond to adversity and suffering, and that we can cultivate meaning from our choices. And so at this point in treatment, patients are guided to directly confront their mortality and start having discussions about what might a good death might look like, and what does it mean to have a meaningful death. And they're also introduced to the Legacy Project, which is application of the concepts that are discussed in treatment that's tailored to the individual patient. So examples include crossing something off a bucket list, or making amends with an estranged loved one, or perhaps writing letters to family or future generations, and so on. It's really individual to each person that's going through the treatment. And creative sources are highlighted by reflecting on ways in which patients express themselves and identifying things that they're passionate about, with the idea that to live meaningfully, it takes courage, creativity, and commitment. And so exploring what their valued activities are, what's getting in the way of a pursuit of those activities, and how can they start engaging in them a little bit more. And lastly, when exploring experiential sources of meaning, patients are reflecting on ways in which they connect with life through the experiences of things like love, beauty, humor, which underscores the importance of these experiences in the setting of their cancer diagnosis. And so taken all together, the aim by exploring each of these sources of meaning is to cultivate a greater sense of purpose and meaning by identifying ways in which patients can start incorporating these sources of meaning into their daily lives and plan of care. And just like the other treatment approaches that we've discussed today, MCP is an evidence-based treatment, and RCTs have shown that it can help reduce desire to hasten death, overall cancer-related distress, and address some existential concerns like enhancing spiritual well-being and leading to overall improvements in quality of life. So if we think back to our gentleman that is living with advanced cancer, what would a course of MCP look like for him? Well, we'd hope that he would be able to identify sources of meaning for him, right? So whether it be his religion or his role perhaps as a father or a grandfather, valuing giving back to the community and time spent with family. He would then be creating goals for his personal legacy and how he can really have more of those meaningful connections for him. So he'd be thinking about ways perhaps that he could be preserving his family memories, or ways he could continue contributing to the community, or creating opportunities to have new memories with his family. And we'd hope that by the end of treatment, we do see some changes in emotional functioning, like improvements of mood and enhancements of purpose. And ideally, he'd also no longer be feeling hopeless or desiring a hastened death. And so in some, we see that MCP can help patients with advanced cancer cultivate a more cohesive identity and sense of purpose with their circumstances and engage with life more meaningfully. Okay, so as a review, the foundation of meaning-centered psychotherapy is heavily influenced by which psychological theory? Yep, so it's, as most of you guessed, it's the existential theory. And we are reaching the conclusion of our presentation, and I know we've covered a wide range of issues related to cancer-related distress and different treatment options, and there are many, many more different treatment options we could discuss. But some takeaways that we hope to leave you with is that cancer-related distress is very common. It can present in a number of different ways and can lead to significant functional impairment. And fortunately, there are many different psychotherapeutic interventions that can address cancer-related distress. We went over just 4 of them today, and tailoring the therapeutic modality to each individual patient really optimizes your outcomes. There's no one-size-fits-all when it comes to therapy. So we hope that you got a glimpse of how treatment can be personalized by matching the case vignettes with different treatments. And at this point, we'd be happy to answer any questions you might have.
All right, Melissa and Lisa, thank you both so much. That was amazing. I'm going to go ahead and advance just so we can see the slide here with poll everywhere. So we are just starting to see some responses come in. And while we wait for a couple of those, I've got a question. So I'm imagining that you could kind of put together a formula or an algorithm, thinking about CBT and ACT and MI and MCP to sort of say, well, this is a factor, this isn't, that one is, that one isn't, and come up with a particular modality. But are there something, so there's two pieces to this question. B, are there some things though that might, let's say, even though somebody has a very advanced form of cancer, there might be some element of ACT or CBT that's even more compelling than MCP and would guide you in a different way, even though things sort of plugged in that way. And then the second part of the question is, to what extent do you find in your practices that you're combining different modalities, either formally or informally? And tell us a little bit about that.
Yeah. Well, to your first question, absolutely. So even though we match each one of these presentations with a particular treatment, that does not mean that that particular treatment is the only treatment that might be helpful for even that different manifestation of cancer-related distress. That's why the clinical interview is really important. So the clinician can get a good idea of what exactly is going on and hopefully present the patient with a menu of options and say, here's ones that I'm thinking are, and really get them in on the decision-making process as well, just to make sure that it's the best fit. So it's not necessarily like we're always prescribing the treatment. If we're thinking there might be a couple that could potentially be very helpful, getting patient feedback is really important as well. And the second question, can you remind me, was?
Sure. Is there either a formal or an informal amount of combining therapies that occurs?
All the time.
I would guess.
Yeah. And it's interesting because I might be working with somebody doing one thing but I find myself communicating in a way that's, what you see in MI. I just think that's a positive way of working with people and helping them, figure out for themselves what they need to do.
And just to add on that, there are times too where there's a lot of overlap with these models, right? Like the values and activities is sort of seen across modalities. So even if you're doing, if your model is primarily couched in one thing, it's very common for folks to integrate and pull from other models as indicated. I'd say the only exception might be if someone was doing like a comprehensive MCP course, right, where it's a group therapy and it's very structured and manualized. You'd probably be less likely to see people drawing upon other modalities. But many clinicians practice for more of an integrated approach.
Gotcha. Thank you so much. And we do have a ton of questions coming in, so we'll go ahead and start taking those. Does UNC have offerings for couples, families, as in the tamoxifen example, mood swings for partners to help work through these times?
Through the Comprehensive Cancer Support Program, we're able to accommodate and work with several people at a time if needed. And then I know that the oncology team is really good too at making sure to educate about side effects of something like tamoxifen.
Gotcha. Thank you. And thanks to our audience for coming up with all these great questions. We have several more. Couldn't DBT potentially be even more helpful when working with this demographic?
DBT is a great treatment for those of you who aren't familiar. It's a form of cognitive behavioral therapy that has some additional interventions incorporated through treatment. It's also designed to be a very comprehensive approach. So comprehensive DBT includes group skills class, weekly individual therapy, and 2 coaching calls in between the week. And so for a patient that might particularly benefit from some of these special skills that are taught, like distress tolerance, emotional regulation, effective communication, it could be a great treatment for this demographic. But again, it's not one size fits all. And with DBT, one of the biggest barriers is just finding programs and resources that offer the comprehensive model.
Gotcha. Thank you so much. Another question. I'm a nurse educator for breast cancer patients prior to starting radiation therapy. Any recommendations on how to prepare patients mentally, emotionally to be undressed from the waist up for the setup and delivery of radiation on a daily basis?
Yeah. That's a great question. I think I'm thinking that it could largely depend on patients. That some patients may have more discomfort than others, depending on just their unique history and particular patient factors. And so it may be always just a good idea just to check in and see if they have any concerns, what concerns they may have, with any of these. With anything, right, it's giving them all the information you can on the forefront to know what they can expect, and just taking every effort to help them feel as comfortable as possible. But that's a tricky one, because I think it would largely depend on what exactly is coming up.
Right.
For instance, if it's trauma related, they might need to work with a professional that could really tailor some of the key issues that are going on, that could liaise with the team even to make sure that everyone knows how to treat this patient in a way that helps them have the most success and adhere to their treatment.
Great. Thank you so much. How would you choose CBT over ACT? I feel like ACT makes more sense in every situation, since acceptance and values, committed action sounds more effective than arguing against negative thoughts that are so valid with chronic illness.
I wouldn't say argue. That I don't argue with patients. I think they're great. And I think ACT is probably used way more frequently than CBT with cancer patients.
Agree. I think that's, particularly Melissa described illogical thoughts, right? Thoughts that aren't grounded in reality. And that's when you might be more likely to use CBT. But so often with chronic illness, the worries that patients are having are not illogical at all, right? They're very reasonable.
Right.
And so that might just give you an indication of I'm not really hearing a distortion here, but it's still causing a lot of distress. So ACT might be a better fit.
I think we probably use ACT more frequently than CBT.
I would agree. Yeah.
Gotcha. Thank you. Last question, and then we do need to wrap up. Are your services available to oncology patients outside of the UNC system if referred by an oncologist?
No. We work.
Yeah.
We work for the cancer hospital. We're supposed to provide services for the UNC Cancer Hospital.
Sure.
One resource that we that can be used for folks that might not be eligible for our services at UNC, if there's not a service available where they get their cancer treatment, is Psychology Today, and we can filter out any of these different treatment approaches. And there are folks that specialize in chronic health issues, so it might be a way to hopefully find a community resource for someone that has a bit more specialized training and things that are unique to cancer patients.
Yeah, that's a great resource. Well, we do need to wrap up. There were no other questions, but we did have some other just very thankful remarks and thanking you for your time and expertise, as do I. This was wonderful. Really appreciate this. I also want to thank the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to thank my colleagues, Veni Obore, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, and Patrick Muscarella for all of their hard work on all varying facets of each one of these lectures. So thanks to them.